Morning.
Okay. So remember when we go through this, the disclaimer is always going to be when you're testing any of the limbs that you test bilaterally uninjured. Is the camera on? Where's the camera? You test bilaterally uninjured arm first. So the first one on your list is impingement sign. It tests all of the structures underneath the subacromial arch, but mainly we're talking about supraspinatus tendon, long head of the biceps, subacromial bursa. Okay? So when you impinge something in general, it's supraspinatus. So there are two tests that you guys can use. You can use a lot more, but under this one, we're going to do something called the Hawkins test. So in the Hawkins test, you're going to raise the arm in flexion to 90 degrees, internally rotate, then the elbow to 90 degrees, and I'm going to continue to internally rotate you. Okay. What that does is it puts the greater tubercle or greater tuberosity in a position where it can indeed impinge upon the subacromial space. So you're basically pinching the supraspinatus tendon in there. You can also do near, so you guys notice this is passive, it's not active. You're not doing anything as the patient, I'm doing everything as the clinician. Okay? With the same mechanism, we could also do nears, except now I'm not bending your elbow, I'm just going to passively flex you to 180 degrees of flexion. Same criteria, pain when I put you in that position is your main criterion for positive test. Ready?
Yeah.
Apprehension test. This one happens to be anterior apprehension, so I'm going to have you lay back. Again, testing both arms bilaterally, uninjured arm first. This one tests for anterior shoulder instability, so history of a subluxation. So come out just a little bit, Alex. I want your scap to be supported still, but right there. So I'm going to put them in a position of vulnerability, which is abduction, external rotation. I'm going to give a little pull here for traction and then externally rotate. Okay? A positive sign would be any sign of apprehension. So wincing, grimacing in pain, turning towards me, withdrawing completely, smacking me in the face, kicking me. Okay? All of those are signs of apprehension. It's not always the patient consciously being apprehensive. I mean, what you're trying to do is the body remembers the position of vulnerability. You put them in it.
Oh no, I was just doing that to show it.
But you put them in that position, the body remembers, and so it withdraws. If you get a positive apprehension test, you can then come back and test it with the relocation test. So relocation, I'm just going to stabilize the head of the humerus. So I'm basically pushing down into the table, and then I'm going to move her arm into external rotation again. Positive sign this time is no response, but that's coupled with a positive apprehension test. Okay, so no response, I let go, and then I get an apprehensive response back, and that's a good way to do sort of a checks and balance, right? So no response, response, no response, response. So that one's called relocation. Test for anterior instability. To test for posterior instability, so again, history of subluxation, dislocation, you can move the arm back into the same position we used to test Hawkins. This time, instead of rotating downward, all I'm going to do is axially load the humerus by pushing it backwards. Okay? So I just push down. Same type of deal. Look for any of the signs of apprehension that would indicate a positive test. Okay. Sometimes I'll put my hand back here too. If I know they have a history and the humeral head will probably pop out, I'll put my hand back here to sort of stabilize. And then I can very quickly sort of move them back into a better position. Glenohumeral glide. Come on this way, Michael. So I'm going to show you two ways of doing this. In some books, I'll reference this as a drawer for the shoulder. Scoot out just there. So I'm going to pin Alex's arm down and make sure that her scap is in contact with the table. I'm going to try and locate her humeral head, and I'm going to draw it forward and push it backwards. So it's an AP glide. Okay. Now the reason I would lay her down is so that her scap doesn't move, because I could sit her up and we could do the same test here where I stabilize the scap and then I draw with this hand. And you notice it's very subtle movement. Okay, it's just So any increased translation compared to the other side would indicate if I'm pulling, anterior instability. If I'm pushing, posterior instability. So that's the positive for that one. Sulcus sign. Sulcus sign tests for inferior instability, so history of an inferior dislocation or subluxation. So this can be done by simply pulling traction on the humerus. So there's a couple ways you can do this. If I have them seated like this, I like to support the arm on their own lap. And then I just pull here, okay? And you're looking for a flattening of the deltoid. So deltoid normally is rounded, it'll flatten out, and you'll see what is called the sulcus there. You could just as easily pull here too. You want to be careful that you stabilize somewhere, so that, like, if I just come and pull, Alex can just pull over, right? So I'm going to make sure I just yeah, I can just make sure I stabilize here, and then it should flatten out. And you'll see, even on, like, go test the water polo players or the swimmers, they're going to have a sulcus. Somebody in that group is going to have a positive sulcus. Speeds test. Stand. Speeds test for bicep tendon pathology. So it could be tendonitis, it could be a tear. You're right, in the books it's very general, but make sure you say something to the effect of long head of the bicep tendon pathology. So there's a few ways to do speeds test. We can do it as a break test. So I'm going to have you raise your arms here. Remember, Nears was palm down. Speeds is palm up. Okay? So hold in shoulder flexion, and I'm going to push down, hold, and I'm going to push down. Okay? So you're looking for weakness and pain, especially in the area of the bicipital groove where the long head of the bicep tendon traverses. If you get a positive there, you can always come back and confirm it by resisting both elbow flexion and shoulder flexion at the same time. And you can test this at a few different angles just to make sure. So the cue will be hold your arm in place. And that makes it simple for the athlete. You don't have to say, oh, I'm going to resist here and here. Just hold your arm here. And then we can test it in a few different places. Relax. Lay down. Hold. Good. If you can confirm your findings by adding that element of elbow flexion. If you don't do it as a break test, you can do this as sort of as an active through the range of motion type test. So Alex is going to lift up. I'm just going to resist. So go. Keep your elbow straight. I'll use one finger. Good. Come over on this side. I'll use one finger. What's funny is when you ask the athletes to do this, let's say this is her injured and this is her uninjured, and you go to push, hold, they both seem to go down. So then I always turn to them and say, okay, what the hell's wrong with this one? I thought it was this one that hurts. So challenge them to hold, because most people should be able to resist one finger, right? I mean, my one finger, and sometimes I'll be a jackass and Alex, hold, this is just my pinky. Okay? And so that will maybe motivate them to be a little bit stronger with it. So that's speeds test. Scapular winging. Let's close this door.
Oh yeah, I've got that one pretty bad.
Scapular winging checks for serratus anterior pathology, but more than that, it is long thoracic nerve palsy. Make sure you write that down. Okay, I want you to do a push-up on the door. So go down, come up, and hold. And so what you're looking for there is for the vertebral border of her scapula to lift away from her rib cage, right? So if this guy comes out like that, and you guys can probably see that on a lot of people. So Alex is okay. You can even see it through her shirt that her vertebral border is trying to stay down. I mean, it comes up a little bit. But this is what you can do. Like, you can really go in and grab that thing. On people that stick all the way out, you don't even have to dig under there. Okay. So positive would be if they wing. And they might not wing on both sides. They might wing only on one side.
I've got a really bad right now.
You do?
Yeah.
You should be the one doing it. Empty can test. Empty can test tests for a supraspinatus strain or tear. So you can test this one bilaterally simultaneously. Bring your arms up. You want to go thumb down as if you are emptying a can of soda. I don't advocate you empty cans of anything else. Okay. Put them in the scapular plane. And this is probably one of the most important points is you got to be in the scapular plane. All right, so the scapula sits at about 60 degrees off the thoracic cage. So 0, 90, 45. Let's come back just a hair. That's about 60 degrees. Okay, so hold. Don't let me push down. Very nice. I'm going to do it with one finger. Don't let me push down. Don't let me push down. If the arm drops, there's weakness and or there's pain, then that's a positive test. The last one in this grouping is O'Brien's test, and you're going to see elements of the other tests that we've done. This one tests for a slap tear, superior labrum, anterior to posterior tear. There are two parts of the test. Both parts have to be positive in order for it to be a positive test. So with this one, we'll test the good arm first. I'm going to bring her arm to 90 degrees of flexion. I'm going to bring her into adduction and then turn her palm downward. Okay. I'm going to push. Don't let me push. Okay. Turn your hand over. This is part 2 of the test. I'm going to push. Don't let me push. Now let's go to the bad arm. So same thing. Let's bring her into 90 degrees of flexion. Let's bring her into adduction. Turn her down into internal rotation. I'm going to push. Okay. Painful click. Painful click is a positive for this one. Now, in order to confirm your findings, you flip the hand. And if I push again, so you're resisting, push, and she resists. If she gets no painful click in this position, then that makes the entire test positive. So painful click here, nothing here. Does that make sense? Okay. If you get pain here and pain here, there's a few things you could be looking for. This, to me, looks a lot like speeds, right? Very similar to speeds. So that could be bicep tendon pathology. If you get pain in both directions, well, this loads up the AC joint. So you might be getting some AC joint pathology as well. So make sure you confirm your findings. You need to take a break, or are you good on time?
I'm good.
Okay. Do you need to take a break?
No.
Okay.
There's just a lot more.
Yeah. Well, there's not. It's like a page and a half. Varus stress test. So we're moving now down to the elbow. This is very, very similar to what we do in the knee. Varus tests for the radial collateral ligament. Same thing in the knee, right? When we're testing the LCL, we're going to test at 2 angles. So 0, and then again, somewhere between 20 and 30. 20 is probably a good answer. So what I'm going to do is I'm going to stabilize with this hand over the medial elbow. I'm going to take my other hand, and the other hand is actually going to do the motion. So it's hold with the top hand, move with the bottom. This is not a natural way to move the elbow. Okay? So if I do this and it moves, it opens up. There's laxity and or pain, and that makes it a positive test. Come back, confirm your findings at 0. Boom. And if it opens at 0, you really have some problems. Okay? You really have some problems because you've taken all of the muscles out of the equation at that point, and we're only looking at the ligament. We're going to flip hands, flip directions, and go to Varus stress test. It tests for the UCL, Tommy John ligament, right? Okay, so same thing. I'm going to test at 20. You'll notice if you go too high that it allows Alex to rotate. So you want to really limit it in the frontal plane. So I'm going to test at 20. I'm going to test at...
Press my elbow.
I'm going to test at 0. Okay. You can also palpate. That's a good point. You can palpate while you're doing the test. So if they have some tenderness. Yeah. This is valgus. We started with Varus. We moved to valgus.
You said valgus again.
Valgus, you said Varus.
Then I said Garris twice.
Yeah, for two tests.
I'll
So
get in the
Garris-
video and edit it.
And then edit it.
You say correction.
Valgus for the second one.
There you go.
I think we got those too.
Medial epicondylitis and lateral epicondylitis. I'll just say them both now, Kanani, so you don't get confused. I'm going to have you sit. And you can do this a few ways. You can have them sitting across from you. If you have them sitting on a table, I prefer that you place their forearms on a stable surface. Okay, so their legs are perfectly stable. Okay, so I'm going to have you resist. I'm going to push down. You're not going to let me. Is that wrist flexion or wrist extension?
Extension.
That's wrist extension. Okay, what structures, or where are the extensors? Are they medial or are they lateral? Those are lateral. So this one is lateral epicondylitis. So hold. I'm going to push down. I'm going to palpate at the same time. Pain when you push down, and weakness can be a part of it, but mainly it sends a shooting pain to the lateral epicondyle when you push down. In the same regard, when we go to test for tennis elbow, no, that was tennis elbow.
Which one were you doing?
Now we're on medial. So golfer's elbow, right? Or little league elbow. Okay, so she's going to hold in flexion. I'm going to push down, and now I'm palpating over the medial epicondyle. Same thing here. Push down, and I'm going to palpate over the medial epicondyle. Just sit in that stool right across from me. And if you want to do this with the table, have them kind of Superman across the table. So, yep. So, fist up, and you can even straighten the fingers. Don't let me push down. Lateral epicondyle. Don't let me push down. Lateral epicondyle. Switch them. Pull up. Don't let me pull down. Don't let me pull down.
Oh.
Don't let me pull down. Don't let me pull down. Well, keep your elbow straight. Keep your elbow on the table. There you go. Don't let me pull down. And that tests for medial epicondyle. So remember FMLE, family. Flexors are medial, lateral are extensors. FMLE. I used to have that on my slide, and then I would have We Are Family playing in the background. Valgus stress test for the fingers or valgus stress test for the thumb. So valgus indicates tear of what? Which side? Medial or lateral collateral?
Lateral.
Medial. Always go back and remember the knee.
Yeah.
Okay. So valgus at the thumb is you might want to zoom in too, Michael. The thumb is kind of rotated. So the UCL for the thumb is here, or the MCL. So hold the first met, and we got to move it in the plane of the thumb. So the thumb's kind of rotated. Like I said, it's rotated probably like 30 degrees. And then we're testing this ligament right here. Okay. You could do varus while you're here too. But valgus, varus. Hold the first met, valgus, and again we're stressing this ligament here, or varus. Go.
Cool.
For at the finger, pick a finger, any finger, pick a IP. So PIP or DIP, PIP, DIP, etc. For the finger, just same concept. You're going to stabilize the more proximal bone, and you're going to move the distal bone. So valgus, varus. Valgus, varus. You want to move it in the frontal plane. Any pain or laxity would indicate a positive test. Phalanx. Phalanx. Hold. You're going to hold for 1 minute, and I want you to push.
Push like my wrists together.
Yep, push your wrists together.
Hold for a minute.
Yep. Let's say a minute has passed.
Okay.
Okay. Now, if she has any radicular symptoms, so pain, or shooting pain, tingling, numbness, that move down her hand, specifically in the median nerve distribution, then that's a positive test.
After you let go?
Yeah, after you let go.
Okay.
You can move to this as well. I don't remember which side is phalanx and which side is reverse phalanx. But the opposite of that is to move to this prayer hands. Same thing, you're going to push hold for a minute, and then you're looking for those symptoms to stay, right? Similar to like if you hit your funny bone, okay, of course you're going to have symptoms for a little bit, but do they remain, right? They should be very transient at best. So median nerve distribution is right down Broadway. Right down Broadway, okay? Finkelstein's. Finkelstein's test for de Quervain's syndrome, or as Alex says, tenosynovitis, right here, okay? So there's a few ways to do this. The way that we do it is not really what Dr. Finkelstein intended. And I know that because I've had countless undergrads look this up and do little one-page reviews of what the test is supposed to be. Take your thumb, insert it into your fist, ulnarly deviate. Does that cause a sharp pain over the sheath of the extensor pollicis tendon? Okay. Yes.
So much pain.
Yeah, it might. It might.
It just stretches it.
So does that pain? If the main thing for this one is pain, does the pain remain? Is kind of the deal with this. Watson's is the next one, and Watson's test for scapholunate instability. Basically, do you have a history of your lunate popping out? Is your lunate currently out? So the first thing I like to do with this one is always find the lunate. And can you feel that shifting?
Yeah.
Yeah, so if you got the lunate and their position is in an open pack position, it means the capsule is loose, then you can shift the bone sort of up and down. You can actually mobilize it.
Does it matter if you do scaphoid first and then find the lunate, if it's easier that way?
Well, lunate to me is the easiest one to find.
Okay.
Because you can find listers, you can find lunate. Here's listers, here's lunate, here's capitate, here's base of the third. They make a straight line right on the back of your wrist.
Okay.
But here's lunate, and if you wanted to start in scaphoid, go here, and then move over one, and then you're in lunate. So when you're in this position, what I like to do is mob it, and then push her into wrist flexion while I'm still applying that force that translates the lunate this way. So dorsally would be the word. But boom, if you get pain or you get any kind of laxity, then that's indicative of a positive test. Come back, find it on this side, mob it first, boom. And again, for me, it's really important to add that little pressure where you're moving the lunate towards the dorsum of the hand. TFCC test for the triangular fibrocartilage complex. That's basically the meniscus of the wrist. So more or less right in this region. Okay. So to test for this, we need to compress this just like we would the meniscus, and then we need to scour it. Okay. So what I want you to do is turn a key like you're starting a car, or pretend this is a doorknob. Hold it, and now open the doorknob. Yeah, or you can say spin a screwdriver. It's really good if you have an old-fashioned doorknob and you lock it and then have them try to turn it. If that causes painful clicking, catching, locking, that's a positive test. The last one is Tennell's test, and Tennell's a generic name for tap the nerve, right? So in this case, it's calling for ulnar nerve. Where's the first place you find the ulnar nerve on your body? I mean, not the first place, but the first place you can ding it and feel it. Right? Yeah. That's your funny bone. Not very humorous. Okay? So you can tap over the ulnar nerve groove here. And of course that probably causes some sort of sensation if you do it right. Or you can tap over Guillen's canal. And that's going to cause some sort of sensation as well. And that sensation is probably like sending shock down to your ulnar nerve distribution, which is your fifth finger and then half of your fourth. Okay, it's not the shock or numbness or tingling part, it's the, does that remain? Yeah, so that could be ulnar nerve pathology. That's it.
And we're done.
All right.
Yay.
How long is that?